All right, good afternoon. My name is Lisa Osipenko and I head Consilium Scientific. Today, we're welcoming my former colleague, Professor Huseyin Naci, who is at the Department of Health Policy at the London School of Economics. Huseyin, welcome. Every paper Huseyin publishes with his team is always of great interest to Consilium because we're looking at very, very similar policy matters. And today's presentation is of particular interest to me because of my prior work at NICE. And it's a very, very important policy topic for UK and worldwide, considering the healthcare issues and drug approval. So, Huseyin, please, the floor is yours.
Thank you very much, Lisa. I hope you can hear me okay, and I hope that my screen is visible for everyone. So my name is Huseyin Naci. I'm an associate professor of health policy at the London School of Economics in the Department of Health Policy. And the title of my presentation today is Trade-offs in Paying for New Drugs in Health Systems. And I will be focusing on an evaluation of new drugs recommended by the National Institute for Health and Care Excellence, or NICE, in England between 2000 and 2020. Before I begin, I'd like to acknowledge my collaborators from the US and the UK. These are listed on the slide here: Peter Murphy, Beth Woods, James Lomas from the Center for Health Economics at University of York in the UK, and Jinru Wei and Irene Papanikolaou from the Center for Health System Sustainability at the Brown School of Public Health in the US. And I should also acknowledge funding from the Commonwealth Fund as part of a Senior Harkness Fellows Grant Scheme. So let me begin with some background. So the context of this study is the National Institute for Health and Care Excellence, or NICE, which was established in 1999 in England to address so-called postcode lottery in access to new drugs in England. NICE is the health technology assessment body in England, and it evaluates new drugs following regulatory marketing authorization. NICE's remit is to make funding recommendations for the National Health Service in England, and local decision makers in England are mandated to make funding available for treatments recommended by NICE within a specified time frame. So NICE bases its recommendations as a health technology assessment body on an assessment of population benefits and value for money. In fact, NICE explicitly states that its assessments consider the opportunity cost of recommending one intervention instead of another. What this means is that NICE, in theory, recognizes the fundamental concept of opportunity cost in health systems. If we allocate limited resources to pay for certain treatments or technologies, these resources are no longer available to pay for other services. NICE's assessments compare not only the clinical effectiveness, but also the cost effectiveness of new versus existing treatments. NICE measures health benefits, or in other words, clinical effectiveness in terms of quality adjusted life years, or QALYs. We can think of QALYs as an overall measure of health that weigh the life expectancy of an individual with an estimate of their health-related quality of life. So we can, to simplify it a little bit, we can say one QALY equals 1 year spent in perfect health or full health. And as mentioned in the earlier slide, NICE assessments routinely include comparative cost-effectiveness analyses. NICE estimates the new treatment's costs and how much benefit it produces compared with the next best alternative or a set of alternatives. The simple formula on the slide shows how NICE evaluates a new treatment's cost effectiveness compared to existing alternatives. This results in an incremental cost effectiveness ratio, or ICER, which is expressed as additional pounds per each additional QALY gain. So in other words, how much more does the new treatment cost to generate 1 more year in full health? And NICE considers typically drugs with an incremental cost effectiveness ratio or ICER between £20,000 and £30,000 per quality gained as cost effective. So we can think of this as NICE's funding threshold. If a new drug's additional costs are not higher than 30,000 for generating an additional year in full health compared to existing alternatives, NICE typically considers this to be cost effective and recommends the treatment for funding. However, there's no empirical evidence to support NICE's current funding threshold that ranges from 20,000 to 30,000 pounds per quality. So this brings me to the motivation of our study. So there have been several analyses over the past decade that examined the relationship between NHS expenditures and health outcomes. In other words, researchers have examined what happened to health outcomes when health expenditures either went up or went down over time. And what these analyses revealed is that the health service in England, the NHS, spends approximately £15,000 on average to generate one additional quality or one additional year in good health. And it's important to note that this figure, this £15,000 per quality figure, is accepted by the UK Department of Health and Social Care. And the department routinely uses it when evaluating the impact of new policies related to pharmaceuticals and other sectors within health. And the implication of this figure is that paying more than £15,000 per additional quality would represent poor value for money and would actually do more harm than good to population health. Against this background, our aim in this paper, in this project that I'm presenting today, was to quantify the net health benefits of NICE recommended new drugs, considering both the value for money of new drugs and the opportunity cost of resources required to pay for them. So our objectives were threefold. First, our first objective was to document the value for money of new drugs recommended between 2000 and 2020. Second, we wanted to characterize the health benefits of new drugs over time and by therapy area. And third, we wanted to estimate the population health impact of NICE recommended new drugs by therapy area. In terms of methods, let me try to summarize our methodological framework using a kind of a simplified illustrative overview, which I hope will help illustrate our kind of the framework that guides our analysis. So the amount of NHS spending for a new drug is determined by NICE's funding threshold for recommending that drug. And that's the 20,000 to 30,000 that I was referring to in the previous slide. So using the NICE appraisal reports, we can see how much health benefits we can expect from that amount of spending on that drug. And using the information I shared in the earlier slide, we can also estimate how much health the NHS can generate for the same amount of money if it was reallocated to other services in the NHS. And the difference between the health that is gained versus what could be gained by reallocating the funding to other services is what I'm going to refer to as the net health effect of a drug. So let me give you an example. In very simple terms, let's say that NICE recommends a new drug for funding at £30,000 per additional quality. We know that NICE expects that the new drug will produce one additional quality or one additional year in full health for that amount of money. And because we know that the NHS can generate one additional year in full health for £15,000 through other existing treatments and services and activities that are already happening in the NHS, this means that reallocating the £30,000 to the NHS could have generated two additional qualities in the system. And what would that mean at the population level? If, let's say, 1,000 patients received the drug, recommended by NICE at this funding level? Well, NICE would expect that the new drug produces 1,000 QALYs for that patient population, but that same amount of 30,000 pounds could have generated 2,000 QALYs if it was reallocated to other treatments and services in the NHS. And the difference between those two numbers reveals the population health impact of the NICE recommendation, which in this case would be negative. So I hope that kind of very simple framework illustrates the methodological kind of underpinnings of our approach, our kind of guiding principles for this work. So in the next slide, I just want to summarize our methodological approach in 3 steps. The first one, and I will go through each of these in a little bit more detail in the next few slides, but here I'm kind of summarizing our methodological approach in one slide. So the first thing we've done in this paper, in this project, was we've identified all new drugs and indications of those drugs appraised by NICE during our time period from 2000 to 2020. So we've gone through publicly available information from the EMA website, from the NICE website, gone through all the final appraisal documents, all the assessment reports, everything that's available to understand what are the drugs that have been appraised, what are the indications that have been appraised, what are the recommendations that NICE has made for those particular recommendations. In the second step, we then systematically reviewed NICE assessment reports and identified the value for money and health benefits associated with new drugs. And this involved, again, going through publicly available information from NICE documents. So these are assessment reports, the final appraisal documents, and all the accompanying documentation that's on the NICE website that gives us an indication about what did NICE committees consider to be the most likely incremental cost effectiveness ratio for their recommendation. What was the incremental quality adjusted life year gain that NICE committees expected from this treatment compared to existing alternatives? And then, if we were not able to obtain this information from NICE documents because of redactions, which are becoming more and more prevalent in recent years, then we've gone to other HTA bodies in other countries, such as in Scotland, to look for similar information in reports available elsewhere. And in some cases, we also had to consult the peer-reviewed literature to understand, for example, incremental quality adjusted life year gains associated with new treatments. And in the third step, we estimated the number of patients, the actual numbers of patients who received the NICE recommended new drugs between 2000 and 2020 using proprietary data from IQVIA. And I will give you a bit more information about how we've done that. And we've also complemented this with publicly available data from peer-reviewed literature. So those are kind of the 3 pillars of our methods for answering the questions that we're interested in, which is what is the population health impact of NICE recommended new treatments over a 20-year period? So let me go through these steps one by one. The first was identifying new drugs and indications appraised by NICE. And for this, we have first identified all of the drugs appraised by NICE, and then we have selected for each drug what were the indications that NICE has considered. These are the different uses of the drug that may have received regulatory approval. How many of those regulatory approved indications did NICE review? How many of those were recommended by NICE? When was the recommendation issued? And for each indication, how many times did NICE appraise them? Were there multiple appraisals available for each indication recommendation? And the purpose of going through these steps was to identify our final sample of product indication pairs that we included in our analysis. And our scope of analysis was limited to new drugs recommended by NICE in appraised indications. So what I mean by that is we defined what we considered to be new drugs, and those were drugs that were appraised by NICE within the first 5 years after regulatory approval. So during our study period, this is approval by the European Medicines Agency. And we only looked at positively recommended drugs by NICE, and we only looked at positively recommended indications of those products by NICE. So that's our sample of products that were eligible to be included in our analysis. Then we extracted information on NICE's decisions for all of those new drugs that were appraised by NICE for all of their positively recommended indications. So our first objective in data extraction was to look for the funding threshold that NICE committees used to support their recommendations. And as I've mentioned already, we've consulted a range of documents, essentially everything that's publicly available on the NICE website. So this included appraisal consultation documents, final appraisal documents, evidence review, group reports, manufacturer submissions, um, and we did this hierarchically. So our starting point was usually the final appraisal document. If that was not sufficient, the appraisal consultation. If that was not sufficient, the evidence review group report. And then if that was not sufficient, the manufacturer submission. So we ensured that we were being systematic and we were doing this as consistently as possible. And this data extraction was done by two researchers independently in parallel and independently verified by myself as well. So that was for the funding thresholds. These are the ICERs that NICE committees used to make their recommendations. We never strayed away from NICE documents for the value for money judgments that NICE committees have made to try to kind of make assumptions about these values. We always use NICE documentation for these. Then, if, for example, for when we're looking at incremental qualities associated with new treatments. These are the health benefits that NICE committees expect to be attributable to the use of the new technology, the new drug, compared to existing alternatives. For those, our approach was very similar to our data extraction for the funding thresholds. We again relied on publicly available information on the NICE website to begin with. But more and more, we have noticed that there were so many redactions for the incremental qualities that were not possible to extract from NICE documentation. And for about 15% of our sample, we had to go outside of NICE documents to extract information on the incremental quality gains associated with new treatments. So first, we went to the Scottish Medicines Consortium, SMC, appraisal documents. Then we went to other appraisals from other HT organizations if we had to. And our last resort was looking at published cost effectiveness analyses to estimate or to extract information on the incremental health benefits associated with new treatments. But this was for very, very few cases where we had to do that. And all of this is very comprehensively documented in our appendix materials of the paper. So that's our data extraction approach. And if there were cases where we were missing information about costs, because costs are so specific to a particular context, we never wanted to extrapolate costs from other HT organizations. And what we've ended up doing was if there were cost information missing from NICE documents, we back calculated these missing incremental cost values using funding thresholds and imputed incremental qualities. And I'm happy to speak about this during the Q&A. So that's our data extraction approach for the paper. Then a very novel approach for this paper was our estimation of patient numbers. So those of you who are familiar with the healthcare system in England and the NHS will know that there's no single comprehensive database that captures all prescribing decisions and data for both primary care and secondary care for the entirety of our study period for 20 years from 2000 to 2020. So we had to come up with a novel way of estimating how many people use these NICE recommended new drugs during our study period. And we relied on data that was provided to us by IQVIA, which is proprietary data on the total volumes of new drugs sold in the UK. And this is the most comprehensive data set available on sales volumes of drugs, all pharmaceuticals in the UK. This data set is very frequently used by the UK government as well when they're looking at utilization patterns and so on. But this data was only available in terms of standard units and defined daily doses. So we don't have the patient numbers. What we have is information about molecules, about products, and how frequently they were used in the UK, in England in particular, during our study period. But what we had information about was not the numbers of patients that received those products. So what we had was standard units, which represents a dose of a particular formulation of a drug. And we had information on defined daily doses, which is the assumed average maintenance dose per day in approved indication. And considering those in combination, we're able to estimate the total patient days on therapy for each of the products in each of their indications during our study period. And by dividing the total patient days on therapy by the mean duration of therapy for each drug in each approved indication, we're able to estimate numbers of patients. And we've done extensive triangulation to make sure that the numbers that we're estimating we're matching to those numbers that we could obtain for subsets of products that were either estimated by NICE in its budget impact models, for example, or by the Department of Health and Social Care or NHS England in other types of reports. So we've done our best to triangulate our numbers and to make sure that they were quite rigorously estimated. And they were representing as close as possible the actual numbers of people who received these medicines in England over our study period. And because the volume data that we had was available at the molecule level and not at the indication level, we had to rely on additional data sources to actually to understand indication splits. And what I mean by that is if we have, for example, data on how much a particular product was used over our study period, well, that use may have been for multiple different indications approved for that product. So we had to rely on repeated surveys of prescribers in England who provided information about what proportion of the use for a particular product is for a particular indication. And by extrapolating from those surveys, we were able to estimate the numbers of people who received NICE recommended new drugs in their NICE recommended indications. So I hope that's relatively clear. This was a painstaking process, and part of the novel contribution that we hope we're making is this new approach to estimate numbers of patients in the absence of a data set that actually captures who received these medicines in the health system. And in terms of estimating the timing of indication level utilization, this is going to be my last slide for the methods. There were some cases that were really straightforward because a particular drug may have been appraised by NICE in a single indication. And therefore, we were able to allocate all of the use of that drug, all of the volume that we observed in the IQVIA data to that single indication appraisal by NICE. But there were cases where a particular drug was appraised by NICE in multiple indications. And in those cases, we relied on the year of NICE appraisal for each of the indications to then attribute or allocate the volumes to each of the individual indications over time. So this was guided by the NICE appraisal dates for different indications for each of the products. Okay, so that summarizes my methods quite hopefully not too succinctly so that it gives you a flavor of everything that we've done. And I will include at the end the reference for the paper that I'm presenting, so that if you're interested, you can take a look and see our extensive method section as well as the supplementary materials. So the next thing I want to do is I want to summarize our findings from this work. So the first thing I want to say is our final analysis sample and what we included in our analysis. So our study sample consisted of 183 new drugs assessed and recommended by NICE between 2000 and 2020. And these drugs were approved for use in 287 different indications. So these are different uses of those approved drugs. And these 287 indications were then appraised by NICE in 339 separate appraisals. So that is our kind of final sample, our data set, if you will, that we included in our analysis. It is important to note that cancer drug appraisals accounted for nearly half of all appraisals during this study period. And more than half of appraisals were actually published between 2015 and 2020. So this is the last 5 years of our 20-year study period. So things are really picking up towards the end of our study period. And the reason, I forgot to mention this earlier, the reason why we stopped at 2020 is because those redactions that I mentioned earlier, the lack of availability of information on the cost effectiveness thresholds that are being used, the incremental quality adjusted life year estimates that are being used to inform recommendations are increasingly not publicly available. And this analysis would not have been possible in more recent years as a result of those reductions. In fact, even during our study period, when we faced a growing number of reductions, we've done freedom of information requests to obtain that information, which were declined actually for this, and we mentioned this in our paper as well. So that's our sample, and the first set of results I will summarize here are looking at the health benefits of new drugs recommended by NICE over the 20-year period. So when looking at the health benefits of new drugs recommended by NICE, the median QALY gain across all appraisals was 0.49. What that means is it's kind of equivalent to an additional half a year in full health. That's the product level health gain that we're observing over this 20-year period. And there was a modest increase in the median quality adjusted life year gains associated with new treatments during the study period, as you can see, going from the first 5-year bucket, 2000 to 2004, all the way to 2015 to 2020. What I'm showing you is the median. Those numbers are corresponding to the median incremental QALY gain for the appraisals during those periods. And then the box plots are showing the variation of that, the higher bound, the lower bound, the upper quartile, the lower quartile. And so there was a modest increase in the incremental QALY gains associated with new treatments during this period. When we look at the health benefits or the incremental quality adjusted life year gains across therapy areas, there was significant variation, as you can see here. Here I'm summarizing the incremental quality adjusted life year gains according to therapy areas. So you see anti-infectives performing particularly well on the left-hand side, and vascular system treatments, ophthalmology towards the right-hand side, suggesting that they're providing lower incremental quality adjusted life year gains on average during this study period, but particularly large improvements for appraisals of anti-infective drugs. That's one key takeaway from this figure. Here are our findings for the value for money, or in other words, the cost effectiveness of new drugs recommended by NICE. Um, so on the y-axis here, I have the ICERs. These are the cost effectiveness values that NICE committees based their recommendations on. And again, I'm presenting these over time. So the 2000 to 2004 period on the left-hand side, 2015 to 2020 on the right-hand side. The numbers that I'm presenting you here are the medians for the assessments, the appraisals that happened during that time period. The numbers of appraisals that we're observing in each time period are summarized on top of the box plots. And I have various thresholds that I'm including in the figure. So the key ones to focus on are the ones in kind of dark red, dark green. I hope that's visible on your screens as well. It's this dashed line that starts here and another dashed line that's here. And that's the range of the cost effectiveness threshold that NICE uses, ranging from 20,000 to 30,000 per quali. Okay. And this red dashed line is sitting at £15,000 per quali, and that's the NHS's health opportunity cost threshold. So that's how much the NHS currently spends to generate an additional year in full health, to generate one additional quali. Okay. So across the board, the majority of appraisals are recommended on the basis of incremental cost effectiveness ratios that are above above NHS's health opportunity cost threshold, as you can see. And at the very top of the figure, I have this other dashed line, which is sitting at £50,000 per quali, and that's for the study period going from 2009 to 2022, actually. There was an end-of-life criteria that was being used by NICE, which allowed cancer treatments in particular that had survival benefits at the end of life to benefit from a higher funding threshold. And that was set at £50,000 per quali, and that's what that dashed line is showing. And that's usually the higher bound of the cost effectiveness thresholds that are being used by committees at NICE during our study period. That no longer that particular pathway or appraisal approach is no longer there at NICE, and we can talk about what has replaced it. But during our study period, that's a relevant funding threshold to take account of as well. So the key takeaway from this figure is that the median ICER for recommending new drugs increased from the earlier periods to the later periods, going from £24,000 median value to about £28,000 median value. And when we look at the value for money by therapy area, this is what I'm showing you in this slide. So again, on the y-axis, I have the incremental cost effectiveness ratio representing the additional cost per additional year in good health, and significant variation by therapy area, ranging from very cost effective for appraisals of anti-infective drugs to not very cost effective for appraisals of oncology drugs. In fact, oncology really stands out here. The median value for oncology appraisals sits right at £30,000 per quali gained during our study period. So at the median value is at the higher end of the NICE funding threshold. During this time frame, we estimated that 19.82 million patients received NICE recommended drugs in their positively appraised indications. So around 20 million people, approximately. And sorry, I want to go back to this slide. Yeah. And as you can see, when we look at the additional costs associated with that use, those 20 million people who had access to these NICE recommended new treatments, in total, the use of new drugs resulted in an estimated additional cost to the NHS of 75.1 billion pounds. And the area that contributed most to these costs were immunology. You can see that here in the slide, and that is accounting for 25.7 billion pounds, followed by oncology, which sits at 22.7 billion pounds. Additional resources that have been allocated to new drugs recommended by NICE during our study period. And the total figure again is 75 billion pounds allocated to new drugs that NICE has recommended during this period. Let's then look at how much the new drugs generated in terms of health benefits. So that's what I have in this figure. In total, new drugs generated an estimated 3.75 million additional QALYs. Of these, an estimated 1.1 million additional QALYs were attributable to new drugs used in immunology, so that substantial additional financial resources that have been allocated to immunology generated 1.1 million additional life years in good health. And looking at oncology, which was the second largest category of additional resources, for oncology, we estimated that 0.6 million additional QALYs were attributable to those treatments during this period. Let's now look at what the amount of money spent on new drugs in these therapy areas could have generated if that money was reallocated to other treatments and services in the NHS. So in total, the NHS could have generated an estimated 5 million QALYs between 2000 and 2020. Of these, 1.71 million could have been generated with the money spent on immunology drugs, and 1.51 million QALYs with the money spent on new cancer drugs. And this figure really summarizes the key takeaway from our analysis, which compares the amount of health generated with the money spent on new drugs and the amount of health that could have been generated if that money was spent on other treatments and services in the NHS. And this is the picture that emerges. So most therapy areas had a negative net health effect, with the use of oncology drugs accounting for a loss of 0.87 million QALYs at the population level. So negative numbers here on this figure suggests that at the population level, we're actually losing health because of the more cost-effective uses of that money that went into paying for those drugs that were foregone as a result of diverting resources to paying for new drugs. And this is my last slide talking about the results. Importantly, the net health impact of new drugs became progressively more negative over time. So on the left-hand side, on the y-axis here, we're looking at the cumulative net health effects of NICE recommended new drugs at the population level. And as you can see, the numbers are becoming more and more negative in more recent years, which is primarily driven by the net impact of wider oncology and immunology drugs in the latest years. And we estimate that the cumulative population health impact of drugs recommended by NICE was negative during our study period, resulting in a net loss of approximately 1.25 million QALYs at the population level. So let me try to summarize what I think are the key kind of takeaways, implications, and questions that this analysis reveals. So our top line finding is that during the first 20 years of NICE, the Health Technology Assessment Body in England, um, NHS coverage and utilization of new drugs recommended by NICE displaced more population health than it generated. And these results highlight the trade-offs and the implicit prioritization of people who directly benefit from new drugs at the expense of people who don't. What we observe is that NICE, during our study period, increasingly recommended drugs with cost effectiveness thresholds that exceeded the regular cost effectiveness threshold and consistently over the NHS's health opportunity cost threshold. And by doing so, NICE has prioritized patients who could benefit from new drugs and valuing their health gains more than those health gains of patients whose needs can be met elsewhere in the NHS. So those who can benefit from pharmaceuticals and pharmaceutical innovation have been prioritized as a result of these processes and assessments, and this has happened at the expense of other patients whose needs could not have been met by pharmaceuticals, but required other services and activities and treatments in the rest of the NHS. So there's clearly a discrepancy between NICE's quite explicit commitment to the principle of opportunity cost and population benefits and the NHS opportunity cost. Um, so what does that mean? What can policymakers do about that? Well, one policy option is to lower NICE's funding threshold. Um, that, of course, would be very controversial. That could be very difficult because industry would be interested to increase the threshold rather than decrease the threshold, lower the threshold. So this would be a very politically contentious thing to do. But if the aim is to maximize population health with new treatments, then the solution would be quite clear. The solution would be to lower NICE's funding threshold and to match it as closely as possible to the NHS's health opportunity cost threshold, which is around £15,000 per QALY. One other option that we entertain in the paper, that we propose in the paper, is even if we're not able to lower NICE's funding threshold, well, one can at least present committee recommendations relative to the health opportunity cost threshold in the NHS. And what that would do is it would convey the trade-off between individuals who directly benefit from the new treatment and other NHS users who may have to forego access to treatments because of having to divert resources away from other things to pay for new drugs. So if I were to give an example of this, for example, NICE recommended trastuzumab for treatment of people with metastatic gastric cancer in 2010, and the incremental cost effectiveness ratio that the NICE committee suggested or based its decision on was £43,000 and 206 pounds per QALY. So that's clearly considerably higher than the £15,000 per QALY opportunity cost threshold in the NHS. And instead of referring to this decision as a good use of resources of the NHS, good value for money for the NHS, this actually could be expressed as 2.88 QALYs are expected to be foregone for each QALY that we expect to gain from this treatment in this particular use. And this directly shows the trade-off between, yes, those patients who are going to get access to this treatment may benefit. They will gain health. They will improve their health outcomes as a result of accessing this treatment. But the cost, the health cost of that access would be considerably more for all the others in the NHS because their services may have to be diluted, they may have to be cut, they may have to be delayed, disinvested from, and so on to make resources available for this particular use of this treatment. So, of course, this paper is looking at the English NHS context, which, of course, operates under a limited budget. relatively fixed budget year on year, and intense resource constraints. And we are at a time where the most critical performance indicators of the NHS are no longer met. So, what our paper contributes to policy reform discussions that are happening at the moment in England, in the UK more broadly, is that paying high prices for new drugs can actually adversely affect population health in this environment. And even though our findings are very much about the UK context, the English context, the concept of opportunity cost is something that's relevant, that's applicable, that's directly relevant for other health systems as well, even if there are no fixed budgets in other health systems. So with that, I will conclude. So again, top line findings is that a growing proportion of NICE appraisals recommended funding on new drugs at levels considerably above the health system's opportunity cost threshold. And overall, the cumulative net benefit of NICE recommended new drugs on population health in England appears to be negative. And if you want to read more about this, of course, I'll take questions in a minute, but this is the paper, the reference to our paper, which was published early this year. And you can find the reference here, and it's open access, and you can take a look at it in more detail. So thanks again for your attention, and look forward to answering your questions.